extremely grateful to Tunisian Society of Infectious Diseases for this invitation to the first MENA Region Congress and the 34th National Congress of the Tunisian Society, and I wish the best for the organizers. So, why stewardship matters? Of course, we hear every day almost now about the growing problem of antimicrobial resistance, and I'm I'm sure that the audience of this program, this meeting, is the best experts in the world in this part of the region who understand this problem better. We have a huge problem of antimicrobial resistance. The latest data from the Global Burden of Disease show a significant shift from 1990 to 2021 as we see the pattern of resistance. The biggest change that we have seen is that from a bigger problem among the younger age group, the pediatric age group, the neonates, now it has become more of a problem of elderly, obviously because we had better tools now in terms of immunization, better water sanitation, hygiene, which could actually vaccination, which could actually reduce the burden of AMR and infectious diseases, but particularly bacterial diseases, particularly among the younger age groups. So we are seeing a significant problem in the elderly in these days. You can go to these QR codes that I will show. I will add into many of my slides for detailed reading of these papers. In summary, we are expecting around or predicted around 40 million people to die from 2021 to 2050 because of antimicrobial resistance, unless we take significant steps to reduce the burden of AMR. In 2021 alone, we had around 4.7 million sepsis deaths, bacterial sepsis deaths due to or associated with antibiotic resistance. I'm sure you might have heard more region-specific presentations already in this session. But if you take the numbers from MENA, we know that it's around 226,000 deaths in 2021 just because of antibiotic resistance. This is a significant problem we only have to address. If you take the numbers, that's 226 numbers, 226,000 numbers, the 6 leading drug-resistant pathogens that we are talking about, there are 6 pathogens which account for majority of these deaths. And we know all those pathogens. We have gram-negative bacteria, which is a significant problem globally without much of treatment options in many contexts. Another linked problem, which needs all of our attention, is the increasing or rapidly increasing use of antibiotic use. And unfortunately, our region has the highest and most rapidly rising antibiotic use. Maybe we may argue that it's also a sign of increasing access to treatment, but may also we have to look into the pattern of use to get a clearer picture. So sometimes these patterns show that there are things to worry. For example, the inappropriate use of antibiotics is a concern in many of our countries, which has a lot to do with the emerging problem of antimicrobial resistance, as we all agree. So, for example, in this case, you can see third generation cephalosporins, fluoroquinolones. It's very high consumption in our region. Of course, carbapenems is lower, probably because of difficulty in access or cost. So, what is it to do with today's presentation? So, many of you might have read this paper, which just came out a few days ago in Lancet on an estimate of the under-treatment of carbapenem-resistant gram-negative bacteria. So among, for example, about 1.5 million carbapenem-resistant gram-negative bacterial infections in 2019 that they studied in a few countries, 8 selected countries, only around 7% of those patients were treated appropriately. So that's a big gap in the treatment. So this cascade of diagnosis to identification to treatment and cure, that's a significant gap in the availability of data, and also probably linking that to the availability of tests for these infections. This is a serious thing. That's why we need to talk about diagnostic stewardship. So diagnostic stewardship and antimicrobial stewardship, I would see it as a continuum of care. It overlaps a lot between them at several points. And we all are familiar with the clinical pathway of a patient. A patient coming into the hospital, seeing a doctor who may have a provisional diagnosis. They may order some of the diagnostic tests, and then simultaneously start with empirical antibiotic, especially especially in severely ill patients. And then once the test is performed, when the reports come back, we may modify the antibiotic that is being used. We may either stop the antibiotic or change the antibiotics. So there is an overlap, and the initial things of diagnosing, ordering a test, getting the sample processed, and doing the process in the test, and then reporting back the results. That constitutes the diagnostic stewardship. And deciding which is the empirical treatment, and maybe taking authorization to use the drug. And then once the drug is used, monitoring the side effects, reviewing the dose, and then once the culture result come back, modifications in the antibiotic use. This constitutes the antibiotic stewardship. And antibiotic stewardship also involves monitoring what antibiotics used, how much of the antibiotic is used, and what is the outcome of the care. So there is a significant interplay between these diagnostics and antibiotics. Diagnostics is the foundation for targeted therapy, and delayed or inappropriate diagnostics will lead to overuse of empirical use of antibiotics. And we know that in a classic definition, diagnostic stewardship means a coordinated action to improve the use of microbiology diagnostics to guide therapeutic decisions. And it means we have to improve appropriate timely diagnostic testing, including the process of collection of samples, identification of the pathogen, and timely reporting of the results. So the focus is the right test for the right time for the right patient, while antibiotic stewardship, on the other hand, is strategies or coordinated actions to improve the use of antibiotics. And our aim is to reduce the inappropriate use, improve the patient outcome, reduce the resistance, reduce the side effects, lower the cost, and preserve the effectiveness of our available antibiotics. Again, the focus here is the right antibiotic for the right patient, for the right dose and the right duration. And this picture is beautifully capturing the relationship. We start with the right diagnostics, and then it can lead to the right therapeutic action, which means the right drug and the right dose for the right duration of treatment. One important aspect that I would like to highlight here is that, the diagnostic stewardship, of course, it has a very big impact on individual patient care, but it also has a bigger impact on helping countries and hospitals to decide their treatment guidelines. Unless you have a proper diagnostic stewardship in place, your lab results probably will be biased. Your diagnostics algorithms may not be working. If they are not working properly, you may be contributing wrong data to the AMR surveillance system in the country. Because this AMR surveillance data inform the treatment guidelines, there's a significant impact on treatment guidelines if our diagnostic algorithm and diagnostic stewardship does not work properly. So this is more important, not just at the individual patient care, but also in the larger picture of diagnostic diagnostic stewardship playing a role in deciding the treatment guidelines. So this is a very interesting paper from 2017, which was the first time that we found a modern definition of diagnostic stewardship. And again, you can access this paper using this QR code. So here, there are certain general principles. And overall, what is diagnostic stewardship? Practically, if you go back and want to improve on your diagnostic stewardship, it involves modifying the process of ordering the test, performing the test, and reporting the test to improve the treatment. So, for example, in a general principle, there are pre-analytical things that you can consider, and then also during analytical phase and also post-analytical. In pre-analytical, for example, deciding that you will do tests only when the clinical presentation is consistent with an infectious disease etiology. So, reducing the unwanted number of unwanted tests in a microbiology lab. It's not just only for reducing the workload or reducing the unnecessary use of resources, but also it improves efficiency. And also it reduces unnecessary use of antibiotics. I will explain you in the next few minutes with a case study. And also in the pre-analytical, it is important as a general principle to pay attention to how we collect samples. This is sometimes very much overlooked. The number of samples that is collected, the volume of sample that is collected, how it is transported, how it is preserved, how much time between delay between collection and transportation and testing. All these will affect the result, and all these will affect our surveillance. All this will affect patient care. And in the analytical phase also, nowadays there's an increasing focus to use adjunct test to distinguish colonization from infection. Again, this is an important problem in many of our, in many cases of bacterial infection. We really need to differentiate between colonization and infection. So we need to treat only infections. And for that, we need to do adjunct. We'll take an example and see how it is. And finally, in post-analytical, it is increasingly identified as an important factor to not just stop reporting at resistant, intermediate, and sensitive, but also give more information to the treating physician and guide him to take an appropriate decision. That's also important because, for example, as a microbiologist from the microbiology lab, you are better informed to identify certain bacteria that you have diagnosed or detected in the test. But you know that it does not have a clinical significance to initiate treatment. So, as a physician, he will be looking forward to your information and guidance based on your expertise in the area of microbiology. So, I think that's very important to inform that when we report from the microbiology lab to the clinicians in the wards. So this is a, from the 2023 paper from the same team from Oregon, asymptomatic bacteria. This is a classical case, and I'm sure we all understand what I'm trying to say here. Um, Positive urine cultures in the absence of true infection. It's a major reason for inappropriate antibiotic use. And from a regional perspective, I can tell one thing that, many of our countries, when they submit data to the global surveillance system, a significant proportion of the sample specimens are urine samples. Of course, it relates to the diagnostic stewardship. Are we doing a lot of unnecessary urine culture tests? I believe that's the case, and I believe we have a common agreement on this. And there are ways to overcome this. When you conduct a urine culture test, it may yield a positive culture, and that will prompt the clinician to start antibiotics. And in many cases, we know that that patient is asymptomatic. Patient may not need antibiotic. Patient may be on Foley's catheter for a long time. You are expecting colony, of bacteria, which may not indicate infection. So unless you do a real thorough examination of the patient for symptoms, and also one tool that we have is the urine reflex testing. So you do urine routine analysis, or urine analysis, what we call in some part of the world, which tells you like indications of a probable infection. And only when those indications are there, then go for a urine culture. Not every sample should not end up in a urine culture. I think some of the strong evidence have come from US and other part of the world, which shows that once you put in place a system of a reflex testing, you decide on some criteria from the urine routine analysis before you take the sample for culture, that can reduce workload, that can actually increase the positive predictive value, that can increase the effectiveness of the doing cultures, and can significantly reduce the use of antibiotics. And you can see here the number of inappropriate use of antibiotics is only 10% in the post intervention phase, compared to a huge significant proportion of patients receiving inappropriate antibiotic in the pre-intervention phase. Again, the detailed study you can access from the QR code. Another example that I would say in the post-analytical phase is clinical decision support systems. So clostridium difficile testing, again, is a classical case. I'm sure I don't have to explain to the experts in this room. Um, even when we have, one of the things that we all understand is that we can use serial testing, like we do in HIV for confirmation. So here also we now have evolving evidence to support such process in bacteriological testing. So decide on a clinical decision support system if there's an electronic health system in the hospital to prompt and help and support the clinicians whether to do a test at the first place or not. And even if the test is done, decide on initiating treatment only based on certain characteristics. For example, symptoms. If there are more than 3 stools, and if there are more than 3 stools, whether the patient was on laxative. So all these factors need to be factored in before initiating treatment. Otherwise, we will be overusing antibiotics, which is creating more problems in general for other patient groups. So in summary, you can improve how we order microbiology tests. You can prevent certain tests from happening, as I showed, only based on urine analysis results. You can allow a urine culture, for example. In collection, institute strict standard operating procedures. Once you go back to your hospital, look for the SOPs. Go and observe how patients' samples are being collected in the wards. If there is a problem, train the doctors, train the nurses who collect the samples. I think it's very important to observe how samples are collected. Is there a possibility of contamination? How much volume is collected? All those things. In processing, we talked about closed difficile testing. So institute serial testing if possible. For example, you can go for a GDH testing and then toxin testing. Then decide on based on the result. If there is only indeterminate results from this GDH and toxin, then decide to go for a nucleic acid amplification test for confirmation. Again, look for history of diarrhea. Look for history of use of laxatives. And then reporting. This is very important, as I mentioned. Guide the clinicians. Don't expect that the clinicians understand everything aspects of microbiology. So as a microbiologist, when you report back to the clinician, you guide him with some notes. Okay, this is what's the result showing, but also keep this in mind before you start initiating treatment. Now let me go to the in the next few minutes, go to the stewardship, the second component. Of course, it has to go with IPC, medicine, and patient safety. It's very important that we stick to monitoring of antibiotic use in the hospital. I think that the critical component, that is the starting point here, is whether you have data to monitor the use of antibiotic in your hospital. And if so, is there a possibility and acceptance to do some audits? When we say audits, people usually are taken back. We have to build the confidence. We have to build the confidence within the prescribing community that this is to improve the performance. It is not for punishment. And then institute trainings. I think these key things has to be considered before you start implementing any stewardship program. There are several core elements of stewardship. It equally applies to diagnostic stewardship and antibiotic stewardship. So leadership commitment, you have to have some specific person allocated to do this job. And there should be expertise, either lab expertise or antibiotic expertise. There should be an accountability, there should be a champion for diagnostic stewardship and a champion for antibiotic stewardship. Who should be responsible for outcome? Who can report back to the hospital leadership? And then you have to identify interventions. So it's some of the interventions we discussed in the diagnostic stewardship already. Same thing, there are interventions possible in antibiotic stewardship. You have to pick and choose. You cannot start with everything. Maybe it's a pre-authorization for some limited antibiotics, restrictions for the use of certain antibiotics. Start with that. Maybe you start with one or two guidelines, maybe, for example, surgical prophylaxis guidelines. Don't start with everything. And then slowly move to audit and feedback. It requires resources. So don't start with audit and feedback. Start with a small one guideline, then pre-authorization. Of course, you have to have data, you have to have reports, you have to have reviews, and based on all these things, you have to institute training for your healthcare workers, right from clinicians to pharmacists to microbiologists. Of course, we understand the challenges. I'm not going into that, but of course, I am sure there will be deliberations on this. We need to have a cultural shift in the way we approach diagnostics. And we have to understand that our empirical guidelines probably are based on not so well done diagnostic tests. So we have to be very cautious when we go for empirical treatment. So it's a shared responsibility. And from WHO side, there have been a lot of efforts in the recent years. There have been guidelines and tools to help implement stewardship programs in the hospitals, including diagnostic stewardship and antibiotic stewardship. An excellent resource I would focus everyone to focus on the last two things. One is the WHO Access, Watch, and Reserve classification of antibiotics, which is a stewardship tool which helps you to identify which are the drugs which can be used safely as empirical treatment, which have low resistance potential,